Today we are going to talk about the respiratory system development. The respiratory system is a highly coordinated and complex process. It's tightly associated with the digestive system from the beginning. It's divided anatomically into two parts. The upper tract consists of nose, nasal cavity, and pharynx. The lower part consists of larynx, trachea, bronchi, and lungs. The pharynx is defined as a fibromuscular tube extending from the base of the skull to the esophagus, whereas the larynx is an apparatus made of cartilages, muscles, mucous membrane, and ligaments. They guard the entrance to the lower respiratory passages, such as bronchi, trachea, and lungs. It also houses the vocal cords. The pharynx is a part of the throat, behind the mouth and nasal cavity, and above the esophagus and larynx. And it's considered as a part of the digestive system and the conducting zone of the respiratory system. It filters, warms, and moistens air and conducts it into the lungs. It's composed of three sections: the nasopharynx, oropharynx, and the laryngopharynx. The larynx has an internal lining which originates from the endoderm, whereas cartilages and muscles are derived from the fourth and sixth pharyngeal arches. There is rapid proliferation of this mesenchyme, and this causes the change of the laryngeal orifice from the sagittal slit into a T-shaped opening. Now, when this mesenchyme of the fourth and sixth arches, it will change into thyroid, cricoid, and arytenoid cartilages. The characteristics adult shape of the laryngeal orifice will be recognized. You can see in this figure. At about the time that the cartilages are formed, the laryngeal epithelium also proliferates rapidly, which causes temporary occlusion of the lumen. Then, later on, subsequently, the vacuolization and recanalization produce a pair of recesses named the laryngeal ventricles, and these are bounded by folds of tissue which differentiate into folds and true vocal cords. The muscles of the larynx are derived from the mesenchyme of the fourth and sixth pharyngeal arches, so the innervation arises from the branches of the vagus nerve, which are the superior laryngeal nerve and the recurrent laryngeal nerve. These are the nerves that supply the structures which are derived from the fourth and sixth pharyngeal arches. Now, when the embryo reaches approximately 4 weeks of age, the respiratory diverticulum, or the lung buds, appear as an outgrowth from the ventral wall of the foregut. Initially, the respiratory diverticulum is continuous with the foregut. Then, a structure or fold arises which is named the tracheo-esophageal folds. They develop on either side. Then they join together, forming a tracheoesophageal septum. This will separate it from the rest of the foregut. So the foregut is divided into laryngeotracheal tube on the ventral side and the esophagus, which is located dorsally. The caudal end of the laryngeotracheal diverticulum, it will enlarge and form the lung buds, surrounded by splanchnic mesoderm. This diverticulum will expand caudally, and two longitudinal ridges, as I mentioned, the tracheoesophageal ridges, they separated from the foregut. These are the ridges. They appear here in this figure. This is one, and this is the second one. These ridges fuse, forming the tracheoesophageal septum here. This septum will separate the esophagus from the trachea. The respiratory primordium, it communicates with the larynx through the laryngeal orifice. The foregut will be divided into dorsal portion, the esophagus. Here, this is the esophagus, and the ventral portion includes the trachea, and these are the lung buds. The communication of the respiratory primordium is maintained with the pharynx through the laryngeal orifice. This is the laryngeal orifice. Now, this is the respiratory diverticulum. It's connected with the foregut. Then the tracheoesophageal ridges. These are the ridges. This is one, and this is the other one. They will develop, and they meet and fuse at the midline, forming the septum. This septum will separate the esophagus from the trachea. Then this respiratory diverticulum will extend caudally, forming two lung buds. These are the two lung buds. And here is the laryngeal orifice. During the separation from the foregut, the lung buds form the trachea and two lateral outpocketings, which are the bronchial buds. And at the beginning of the 5th week, each of these buds enlarge to form right and left bronchi. Here is, you can see in this figure, these are the bronchi. This is the right one. It gives 3 branches, whereas the left one gives only 2. At the age of 7th month, the capillary loops connected with the pulmonary circulation, it will become sufficiently well developed to support life. At delivery, with the onset of respiration, the lungs expand and the alveoli become dilated. Although after only 3 to 4 days of postnatal life, the alveoli in the periphery of each lung, they become fully expanded. Now, the development of the pleura. Each bud grows laterally. It projects into the pleural part of the embryonic column. The embryonic column originates from the lateral mesoderm. These are the buds. They are, as you can see here, they are projecting into the pleural part of the embryonic column. Each lung will receive a covering of visceral pleura and parietal pleura. The visceral pleura is derived from the splanchnic mesoderm, and the parietal pleura will be formed from the somatic mesoderm. This is the dorsal part of the lateral plate mesoderm, and this is the ventral part of the lateral plate mesoderm. Here is the intraembryonic mesoderm surrounding the notochord. This is the paraxial, intermediate, and lateral. The lateral plate mesoderm is divided into the dorsal part, and this is the ventral part. The lateral mesoderm, as you can see here, the splitting into 2 parts, the resulting cavity between the somatopleur and the splanchopleur is called the intraembryonic mesoderm, which has a connection with the extraembryonic mesoderm. Here, the intraembryonic mesoderm. Another figure shows the column. This is the dorsal division of the lateral plate mesoderm, and this is the ventral one. Here again, the trachea and the 2 bronchi divided into 3 branches on the right side and 2 branches on the left side. Now, maturation of the lung is divided into many phases. The first one is named the pseudoglandular period or phase, where the branching has continued to form terminal bronchioles. There is no respiratory bronchioles or alveoli are present at this stage. The canicular phase or period, it's up to the 7th prenatal month. The bronchioles will divide continuously into more and smaller canals. The vascular supply increases steadily at this stage. Now, the terminal sacs or primitive alveoli occurs at this phase where the respiration becomes passable. Some of the cuboidal cells of the respiratory bronchioles, these are the lining cells of the respiratory bronchioles, they change into thin, flat cells. They are intimately associated with numerous blood and lymphatic capillaries, surrounded by spaces known as the terminal sacs or primitive alveoli. During the 7th month, sufficient numbers of capillaries will be present to guarantee the adequate gas exchange and the premature infant is able to survive. Here, this is the respiratory bronchiole, and this is the cuboidal lining. They're surrounded by blood capillaries. And here you can see these cells are changed into flat, thin cells. They are in intimate contact with the capillaries. The remaining cells remain cuboidal. Only these cells will be flat and thin. Now, the fourth stage is the alveolar period. During the last 2 months of prenatal life and for several years thereafter, the number of terminal sacs increases, and in addition, the cells lining the sacs, they are known as the type 1 alveolar epithelial cells. They become thinner, so the surrounding capillaries protrude into the alveolar sac. Mature alveoli are not present before birth. The other cell type is known the type 2 alveolar epithelial cells. They are responsible for the production of the phospholipid-rich fluid, which is known as a surfactant. This surfactant is capable of lowering the surface tension at the air-alveolar interface. Surfactant deposited as a thin phospholipid coat on the alveolar cell membranes. Without the fatty surfactant layer, the alveoli will collapse during expiration. Atelectasis. Here you can see these cells. They become thinner, and they will be these capillaries will project into these cells. These are lymphatic capillaries. This is mature alveoli. As you can see, the cells, the remaining cells remain cuboidal. Fetal breathing movements begin before birth and cause aspiration of amniotic fluid. They are important for stimulation of the lung development and conditioning respiratory muscles. At birth, the respiration begins, so most of the lung fluid is rapidly resorbed by the blood and lymphatic capillaries, and a small amount is probably expelled via the trachea and the bronchi during delivery. Growth of the lungs after birth is primarily due to an increase in the number of respiratory bronchioles and alveoli, and not to the increase in the size of the alveoli, so only the number will increase. New alveoli are formed during the first 10 years of postnatal life. Some of the congenital anomalies may occur during development of the system. These are a product of errors in embryogenesis or a result of intrauterine events that affect the embryonic and fetal growth. The more the complex the formation of a structure, the more opportunities of these malformations to occur. Arrhythmia, it means nasal agencies, is the congenital partial or complete absence of the nose at birth. It's a rare condition, generally classified as a craniofacial abnormality, and the cause is unknown. You can see in this figure, it's a newly born baby, and this picture also, lateral profile. Another deformity is choanal atresia. It's a congenital disorder when the back of the nasal passage, the choana, is blocked, usually abnormal bone or soft tissue membranous, so it's either blocked by bone or soft tissue due to failed recanalization of the nasal fossa during fetal development. Here you can see this is blocked here side, and this is also blocked. This is bilateral choanal atresia. The laryngeal, it refers to a congenital anomalous air sac communicating with the cavity of the larynx, which may bulge outward on the neck, as you can see in this figure. It could be acquired, not congenital, seen in glass blowers due to the continual forced expiration produced. This increased pressures in the larynx, which leads to dilatation of the laryngeal ventricle. This is internal laryngeal seal. This is external, it bulges outside of the neck. This person could be a glass blower. Now, the pulmonary hypoplasia is incomplete development of the lungs, result in abnormally low number or size of bronchopulmonary segments or alveoli. It's most often occurs secondary to other fetal abnormalities that interfere with normal development of the lungs. The primary or idiopathic pulmonary hypoplasia is rare and usually not associated with other maternal or fetal abnormalities. Respiratory distress syndrome is a common breathing disorder that affects newborns. This occurs when the surfactant material is not sufficient, and this causes the air, water, or blood surface membrane tension high, and bringing great risk that the alveoli will collapse during expiration. As a result, the respiratory distress syndrome develops. It's a common cause of death in the premature infant. Thank you for your listening.